Assalamu alaikum. Juvenile recurrent parotitis, the recurrent parotid gland inflammation of childhood, is the second most common inflammatory condition of the salivary gland in childhood, second only to mumps. This is an inflammatory disorder of the salivary gland, affecting almost always, but not exclusively, the parotid glands. It's of a non-obstructive nature. The ducts are actually widened rather than narrowed or blocked. It affects children up to the age of 16. There is a somewhat different version of the disease that affects adults. It's usually unilateral, affecting one parotid at a time, but occasionally, in less than a fourth of the cases, it may affect the two glands. And it is recurrent, then children would have 2 or more episodes before puberty, sometimes up to 10 episodes in a year or more. The condition was described almost 70 years ago by Rose. It's the most common childhood parotid gland inflammation in the areas of the world where mumps vaccination is widespread. The attacks can be as frequent as more than 10 episodes per year. The majority are unilateral, somewhere between 2/3 and 3/4 of the cases, but in about 1/4 of the cases it can be alternatingly unilateral between the two sites. What age? It can arise at any age. The age of onset can be of bimodal peaks. A peak incidence between the ages of 3 and 6 years, and another peak incidence between the ages of 9 and 11 years. The vast majority of the cases would have their symptoms resolved before adolescence, 92% or so. The juvenile recurrent parotitis affects usually males more than females. The adult version of recurrent parotitis would actually affect females more than males. How often would the condition recurs? The episodes of localized pain and swelling of the parotid gland can recur every several months, sometimes more often. The number of episodes can vary between 1, 5 per year, 10 per year, up to 20 episodes per year. The frequency of the recurrence peaks between the age of 5 to 7 years of age. The child is completely free of symptoms between the episodes. The onset of the inflammatory episode is usually sudden, with a rapid increase in the size of the affected parotid gland, usually on one side. There would be an overlying erythema of the skin and pain in the parotid gland, and there would also be fever. If the gland is gently pressed or massaged, a whitish discharge could be expressed from the parotid papilla. The parotid papilla itself would always be hyperemic. The acute episode would last anything between 3 and 7 days, but this can extend up to 3 weeks in some severe forms. Often, the first episode of the parotitis is attributed to mumps before the true nature of the disease is diagnosed. In areas where there is widespread vaccination against measles, mumps, and rubella, the MMR vaccine, the incidence of mumps is now next to 0. It's highly unlikely that the children will be affected by mumps after 2 doses of the triple vaccine. A clinical diagnosis can be established based on the criteria suggested by Gravello et al. These include some inclusion criteria, but also a set of exclusion criteria as well. The inclusion criteria would describe an inflammatory recurrent parotitis in a young child before the age of 16, affecting 1 or the 2 parotid glands, and at least 2 episodes during the preceding 6 months. But for the diagnosis to be established, the exclusion criteria includes things like obstructive lesions of the parotid gland, like stones or strictures, Sjogren syndrome, dental malocclusion, and congenital IgA immunodeficiency. These conditions should be excluded before establishing the clinical diagnosis. What causes the juvenile recurrent parotitis? There are still some unanswered questions. Originally, in the past, it was thought that the JRP is due to congenital malformations causing dilatations in the parotid duct that would make it easier for ascending recurrent infections of the gland. Now, a multiple approach to the etiology is more accepted. There is some genetic base for the etiology. The JRP presents as an autosomal dominant pattern, however, with an incomplete penetration and also a variable expression. That's why it's not very common despite it being an autosomal dominant condition. There may be any of the following. There may be some impaired flow rate of saliva secretion, some primary or secondary infection in the gland, and there may be a systemic immunoglobulin disease with a local manifestation in the parotid, and various other factors were suggested, including hypoglobulinemia and immunoglobulin A deficiency, and also immunoglobulin G3 deficiency. How the disease develop? The most significant element in the development of the disease is this: the dilatation of the parotid duct. This sialectasis, perhaps combined with decreased salivary production as well, would favor ascending infection of the parotid gland through the oral cavity. This would cause partial obstruction of the ducts with mucus plugs sometimes, or debris or inflammatory exudate, and this would result in further dilatation due to the kinking or the partial obstruction of the duct. Also, there would be some distortion of the duct itself, as you could see, and with an inflamed areas and fibrous healing of these inflamed areas, some strictures could also be noted. Despite the generalized dilatation, there would be localized strictures in many areas, giving the duct this beaded-like appearance. And then metaplasia of the covering epithelium would cause excess mucus production and mucus plugs, and this would cause further reduction in salivary flow rate and predispose to recurrent infections. Several structural changes were noted in the affected glands, but there are still a debate about whether these structural changes are the primary cause of the disease or secondary to repeated attacks of inflammation. The structural changes noted are intraductal cystic dilatation, the sialectasis of the duct system of the parotid gland. This usually measures 1 to 2 millimeters in diameter and can extend from the distal ducts to even the intraglandular deep parts of the gland, and cause cystic dilatation not only of all the duct system but also of the parotid acini. In addition to the sialectasis, the other important structural change would be a periductal lymphocytic infiltration. The lymphocytic infiltration would be surrounding the ducts rather than the blood vessels in other diseases, for example. In the JRP, there will be massive infiltration of lymphocytes with lymphoid follicle formation surrounding the duct system. The preliminary basic investigations in the cases of juvenile recurrent parotitis would include a blood picture, which would show an elevated white cell count and an elevated C-reactive protein reflecting the inflammatory nature of the condition. Serology, serological markers may be particularly useful in the first episode to exclude mumps. Serum amylase may be elevated due to the inflammatory nature of the condition on the salivary tissue. And if mucopus could be expressed from the parotid papilla, then a culture could be also useful. Other forms of investigations are mainly focused on the exclusion of other conditions to establish the disease. Most of the other conditions of the differential diagnosis are related to immunodeficiencies. So things like anti-neutrophil cytoplasmic antibodies, ANCA, and the anti-RO and anti-LA antibodies are also measured to exclude Sjogren's disease, anti-nuclear antibodies, and often a rheumatology consultation. Sometimes an ultrasonography is used for definitive diagnosis, but also parotid sialography or Sialoendoscopy can be very useful in establishing the diagnosis and also in the treatment of the condition. And fine needle aspiration cytology is sometimes needed to exclude conditions like lymphomas, malignant lymphoepithelial lesions, or benign lymphoepithelial lesions. For the differential diagnosis of the juvenile recurrent parotitis, for the first episode, mumps may be considered, but it should not be considered in cases of recurrent parotitis. In this case, when the condition recurs, the differential diagnosis includes conditions blocking or obstructing either partially or totally the parotid ducts, including stones or duct strictures or congenital malformations. The other group of conditions included in the differential diagnosis are the autoimmune diseases, including Sjogren's disease, and the malignant or the benign lymphoepithelial lesions. A consultation with a rheumatologist would then be of some help. To confirm the diagnosis of juvenile recurrent parotitis, ultrasound scan is essential. This is the #1 imaging modality chosen in this condition because it's non-invasive, it's cost-effective, and quick imaging modality. It's useful in the diagnosis and also for follow-up purposes. The basic criteria are enlarged gland and heterogeneous echo. Enlarged and heterogeneous echo with multiple areas of hypoechoic, always millimeters, like 1 or 2 millimeters in diameter, surrounded by these areas of lymphocytic infiltration. So these are the basic features: multiple hypoechoic areas of millimeters in diameter, surrounded by areas that resembles the periductal lymphatic infiltration. These hypoechoic areas would give the appearance of a Swiss cheese or a moth-eaten enlarged heterogeneous gland. The areas of the lymphocytic infiltration would give a hyperemic echo on the Doppler and are usually surrounding the sialectatic areas, the hypoechoic areas. Parotid sialography entails the installation of a radio-opaque material into the duct system, usually iodine-based. This would give a very clear image about the duct system, including its caliber and its arborization up to its very peripheral ducts. The features in juvenile recurrent parotitis are basically a dilatation of the distal duct that extends either to the two-thirds or the whole of the gland, depending on the severity of the condition. This dilatation can also be associated paradoxically with some narrowing, some narrow segments of stenosis that are usually due to the inflammatory process and the healing with scar tissue. There may be also kinking of the duct system and distortion of the distal duct. These are the characteristic features of the parotid sialogram in juvenile recurrent parotitis, and this imaging modality can also help in classifying the condition to mild, moderate, or severe according to the extent of the disease into the 1/3, 2/3, or whole of the parotid gland. The classification system was proposed by some contribution from Choi, Blatt, and also Z. It basically classifies the juvenile recurrent parotitis into 3 grades. The mildest form, grade 1, entails slight changes in the sialectases and extension of the changes into 1/3 of the entire intraglandular area. Grade 2 would reflect moderate changes extending into the 2/3 of the glands, and this would affect almost half of the cases. The grade 3, which is rare, affecting only 7% of the cases, would entail the extension of the disease process into the whole of the parotid gland, with severe dilatation, sausage-like appearance of the distal duct. MRI scans and MR sialography are usually reserved for some special cases. It shows the basic pathology again, with some areas of sialectasis surrounded by the lymphocytic infiltration and diffuse enlargement of the salivary gland itself. Very similar features will be seen in CT scans and Sialo-CT scans. All these are not usually required routinely in cases of juvenile recurrent parotitis. Areas of sialoctasis seen here as reduced density surrounded by the periductal lymphocytic infiltration and the heterogeneous enlargement of the affected parotid gland. Parotid Sialoendoscopy is useful not only in confirming the diagnosis, but mainly for the management of the condition. It shows some features of the disease, including the dilatation of some segments of the distal ducts and localized stenosis due to fibrosis in some parts, multiple stenosis in some parts of the dilated ducts. You can see mucus plugs inside the ducts and scar tissue in the mucosa, but the characteristic appearance would be this whitish lining of the inside of the duct due to the squamous metaplasia of the repeatedly inflamed duct surface, and you can no longer see through the thin epithelium the blood vessels underlying the duct lining. This whitish appearance of the duct is considered by some a characteristic feature of the disease. It's useful in confirming the diagnosis, but similar features can also be seen in other autoimmune conditions, including Recurrence disease. Several reports about the frequently encountered findings in the Sialoendoscopy of juvenile recurrent parotitis. In some reports, the most common finding was the presence of some multiple stenosis due to the recurrent scarring, seen in 95% of the cases, followed by the pale duct, the whitish appearance of the ductal layer with debris inside the duct system. Seen in the pale duct in 71% and the debris in about 50% of the cases, and mucus plugs in about 1/3 of the cases. Other reports would show different percentages for the same findings. The whitish appearance and the lack of vascularity would be seen in 75%, very comparable to this, and the multiple debris would also be seen in almost half of the cases, quite similar to the other report. Generally speaking, the percentage of the reports indicating multiple stenosis would be higher than the percentage of the reported dilatation by different authors. And now to the management of juvenile recurrent parotitis, and these include a long list of suggested therapies, including symptomatic treatment with painkillers and antibiotics, analgesics, intraductal injection of saline with or without dilatation of the duct, or installing antibiotics or antiseptic solutions, or steroids. Also sialography with high concentration of iodine, or Sialoendoscopy with duct dilatation with balloons in the multiple stenotic segments. Other forms of treatment used in the past, like ligation of the duct or injecting a sclerosing agent in it, radiation of the parotid, or even parotoidectomy or tympanic neurectomy have fallen out of favor. Most of these other forms of treatment are no longer used. Aggressive management is no longer used because we know that 92% of the children would have their symptoms resolved spontaneously at adolescence. So the conservative approach to the management is usually tried first in anticipation for the spontaneous resolution of the condition. It's only in the very severe cases that invasive treatment, including Sialoendoscopy or injection of high iodine concentration in Sialography, may be considered. The conservative management includes things like painkillers, oral hygiene to prevent ascending infection, massage of the parotid gland to try and empty the gland of the infected material and the accumulated saliva and mucus, application of heat to the affected inflamed area, and using things like chewing gums or sucking on a sour candy to stimulate the flow of saliva that may flush the duct system out of all the infected material and the retained saliva, and maintaining good hydration, which also helps in the promotion of salivary flow rate. Also, some salagogues, drugs that stimulate the salivary flow, can be tried, and antibiotics. Why antibiotics should be included in the conservative management? Because almost always, up to 91% of the cases, positive bacterial cultures can be obtained from the saliva samples from the affected children. The most common organisms will be Haemophilus influenzae at 40%, followed by Streptococcus pneumoniae, almost 40% again, Streptococcus viridans, just a little bit less, but also other types of organisms, including Moraxella and anaerobes in 4 or 1%. The antibiotics therapy should be targeted against the expected gram-negative and gram-positive aerobic organism and anaerobes if this is detected in the saliva. A recent report, a retrospective study of 10 years and over 41 patients with juvenile recurrent parotitis, concluded that clindamycin is an effective antibiotic for the initial treatment. The efficacy of the antibiotic therapy in cases of juvenile recurrent parotitis is confirmed by several other reports, including this report from Schneider, with a long-term follow-up of patients who have been either treated with antibiotics or Sialoendoscopy, that showed that the outcome between the two modalities was very similar in terms of reduction of the frequency of the episodes of recurrences and the severity of the symptoms. Antibiotics is equal to Sialoendoscopy in reducing the number of recurrences and reducing the symptoms, but it would not decrease the duration of any single episode. This has been shown by several other reports. Another report had showed that even if Sialoendoscopy is chosen for the management, patients who had antibiotics or medical treatment before the Sialoendoscopy had better results than those who had Sialoendoscopy alone. The other medication of confirmed efficacy in the non-invasive medical treatment of juvenile recurrent parotitis is systemic steroids, particularly prednisolone. This long-term reports of over 10 years follow-up had showed that a single dose of prednisolone taken in the first day of the episode at a dose of 0.5 milligrams per kilogram body weight would actually cause a dramatic response in terms of pain control and control of the severity of the symptoms and the rate of the recurrence. Over a 10 years period of follow-up, it was shown to be effective, fast, and inexpensive treatment, medical treatment for juvenile recurrent parotitis. Of the other forms of management for the juvenile recurrent parotitis, it was noted that sialography, parotid sialography with a high concentration of iodinated oil, is not only diagnostic but also of therapeutic value. This can be attributed to the antibacterial, antiseptic effect of the iodine in high concentration, and because of the sialactases, the iodine would remain longer within the gland, causing a more pronounced local antiseptic action. Also, the mechanical force during the installation of the dye within the duct system could help in forcing more dilatation to the stenotic or the kinked segments, together with the flushing of the system with saline prior to the injection of the dye, and also the dilatation of the papilla, the Stenson duct created before the cannulation of the parotid duct before the sialography. All these combined factors, the clearing of the mucus plugs, the injection of the dye itself, the dilatation of the papilla, and the mechanical force help in the therapeutic antiseptic effect of the iodine in the management of the condition. The therapeutic efficacy of parotid sialography with high concentration of iodinated oil in the juvenile recurrent parotitis management was confirmed by several recent reports, including this report from Italy, in which Tucci had shown that out of 110 patients, 89% reported improvement in their symptoms, with a 2/3 decrease in the number of episodes after the sialography. Same was reported by others, including 100% reduction in the recurrences in a series of 87 patients, and a good improvement in the results in a large series by cats of 840 patients. When Sialoendoscopy is used in the management of the recurrent parotitis in children, a part of the procedure is to infuse the duct system with a steroid solution with good results. And some authorities have suggested that the good results are actually due to the installation of the steroids alone. This prompted this study in which the results of Sialoendoscopy and steroid infusion were compared to steroid infusion alone, duct corticosteroid infusion alone, without Sialoendoscopy, in the treatment of the recurrent parotitis in the children. And the results were very similar, suggesting that the application of the corticosteroids is a factor that caused the improvement in the disease symptoms. All patients had longer duration between the episodes, less frequency of the episodes. 75% of the parents of the children were happy with the results of the steroid infusion alone, and it's now a suggested form of treatment is to infuse the duct system with hydrocortisone solution without a Sialoendoscopy. The results of this ductal corticosteroid infusion, DCI, is that about 58% of the patient would not have any further recurrences of the condition. The remaining 42 would have less frequent episodes of the condition compared to preoperative values. The other form of management is Sialoendoscopy. This is often required when the intensity or the frequency of the episodes are severe. A more aggressive form of treatment may be then considered. This would entail the Sialoendoscopy and irrigation or rinsing of the duct system, first with saline solution during the endoscopy procedure, use of balloons to stretch and dilate the multiple strictures, clearance of the debris and the mucus plugs, and sometimes installation of steroids as well into the duct system. The efficacy of Sialoendoscopy in the management of JRP was recently reviewed. This large systematic review had looked into more than 1,000 articles with different outcomes. 27 of them were included in the systematic review, covering a period of 17 years. The mostly retrospective series, observational studies, many case series, and also 3 systematic reviews. The average follow-up after the operation was more than 19 months, and some operations had been repeated in about 1/7 of the cases, with a range between 0% repeated operations or 1/4 of the operations was repeated. The studies included ranged a series between just 3 patients or 77 patients. And the bottom line was this: the mean recurrences after Sialoendoscopy is about 1/4 of the cases. And there is a significant relationship between the recurrence rate and the preoperative frequency of the attacks per year. The higher the number of the attacks, the less is the success rate, and the more is the chance of a recurrence after the procedure. The recurrences were also analyzed according to the type of the irrigation solution used during the endoscopy, and it was found that this actually made no significant difference between the use of either steroids alone or steroids with antibiotics or just saline solution in the rate of the recurrence. What really matters is the frequency of the attacks before the operation. The bottom line rate of recurrences, the 25%, translated into 75% success rate, is the same as in other big series, including the one from Kanzi with 179 children. Success rate is 78%. A success rate of 73% is also described in a big series of 120 patients, and a failure rate or a recurrence rate of 24%, similar to this bottom line effect, was described by Gravello et al. Recently. So 25% of the patients after Sialoendoscopy would have recurrences, but this is related to the frequency of the episodes before the operation. So if you have only about 2 episodes in a year, you have a lower recurrence rate between 20 and 24. If you have 2 episodes every 6 months, it's not too far, between 21 and 25%. But if you have 5 or 6 episodes in 6 months or a year, then the recurrence rate would be almost between 44 and 49%. But this average success rate after Sialoendoscopy of about 3/4 of the patient can only be achieved after repeating the Sialoendoscopies several times. The average would be 3 Sialoendoscopic procedures to achieve the average success rate of 3/4 of the patient. If only 1 Sialoendoscopy procedure is performed, the success rate is actually less than 50%. After a second procedure, an extra 17% will be added to this, and after the third procedure, an extra 11% success rate will be added. So ultimately, the 76.5% success rate would only be achieved after 3 Sialoendoscopies. By this, we come to the end of this presentation on juvenile recurrent parotitis in children. Assalamu alaikum.